This presentation was designed to highlight the importance of pharmacokinetics in pediatrics. Pharmacokinetics and pharmacodynamics go hand in hand to determine optimal drug dose. But pharmacokinetics is of the utmost importance, so that will be the main focus of this presentation. There are 4 factors that influence pharmacokinetics, and they are the ADME, which stands for absorption, distribution, metabolism, and excretion. Firstly, absorption. Orally administered drugs must undergo absorption in order to reach systemic circulation. In the GI tract, there are several age-related factors that affect drug absorption. Firstly is the gastric pH in the gut. Gastric pH is neutral at birth, but falls to pH 1 to 3 within 24 to 48 hours after birth. Then, the pH gradually returns to neutral and will slowly decline again to reach adult values after 2 years of age. So the pH is higher in neonates, and young infants can produce a protective effect on acid-labile drugs, increasing their bioavailability. Other factors such as prolonged gastric emptying time, reduced intestinal absorption surface area and motility, and shorter gut transit time can cause delayed absorption of orally administered drugs in kids. Children also have a higher percutaneous absorption, and this is due to better hydration of the epidermis, greater percussion of the subcutaneous layer, and larger total body surface area to body mass ratio. Intramuscular absorption varies compared to adults, and the pharmacokinetic implications are unknown. Distribution. Once the drug gets absorbed into the bloodstream or plasma, it gets distributed to different areas of the body. The volume of drug distribution depends on the body fat, water content, and plasma proteins. Total body water decreases, while body fat increases with age. Therefore, children have higher total body water to fat ratio than adults. As a result, the volume of distribution of hydrophilic drugs increases, while it decreases for lipophilic drugs. Another factor that affects drug distribution is plasma protein binding. Children have reduced total amount of plasma proteins and diminished binding affinity. This reduced protein binding causes an increase in volume of distribution and concentration of unbound drug, which is the pharmacologically active component. Metabolism. The purpose of drug metabolism is to increase drug hydrophilicity to enhance its renal excretion. Metabolism is divided into phase 1 and phase 2. Phase 1 metabolism involves small alterations of drug molecules, and the majority of its action is mediated by the cytochrome P450 enzyme. Phase 2 metabolism involves functional group conjugation, and a particular enzyme group of interest is the UGT enzymes. Both phase 1 and phase 2 isoenzymes are immature at birth, and their activities increase with age in a non-linear manner. As a consequence, children have reduced hepatic clearance that require age-related dose adjustments for some drugs. Lastly, we have excretion. This is the last factor that impacts pharmacokinetics. Drug excretion by the kidneys depend on glomerular filtration, tubular secretion, and tubular reabsorption. All these 3 processes are reduced in children. The renal clearance can be calculated using this formula. Immature renal clearance processes can result in inefficient elimination of drugs and prolonged half-lives, so because of this, the dose for drugs that are mainly eliminated by the kidneys should be reduced. A 23-month-old baby boy was discovered to be unresponsive and having blue-purple colorations of the skin after carbamazepine therapy. His guardian placed him on the floor and CPR was performed until paramedics arrived. He was immediately sent to the emergency department. Being asystolic and having a Glasgow Coma scale of 3, advanced cardiovascular life support was performed. However, spontaneous circulation was not returned and the child died. He has a past medical history of febrile and epileptic seizures, which he was treated with carbamazepine and phenytoin, which started 5 months ago. He weighs 12.5 kilograms and receives a daily dose of carbamazepine, 100 milligrams, which has been increased to 500 milligrams over the past 5 months. Phenytoin 100 milligrams was stopped 29 days before his death.